Hello, my name is Mark Douglas Sukumpf, and welcome to Loyola University Medical Center's Introduction to Ultrasonography for the Emergency Medicine Clerkship. Today we will be discussing bedside imaging and the evaluation of right upper quadrant abdominal pain. As we will soon see, gallbladder disease is well suited to emergency ultrasonography, as presence of findings upon the exam, taken with the clinical picture at large, can lead to a confirmation of a presumptive diagnosis of acute cholecystitis or rapidly narrow the differential. Severe abdominal pain localized to the right upper quadrant may be caused by sudden inflammation of the gallbladder, a condition called acute cholecystitis. Over 90% of such cases are caused by gallstones obstructing the cystic duct or cholelithiasis. Blockage of the duct results in accumulation of bile within the gallbladder lumen, which irritates and damages the wall. As the gallbladder becomes distended, blood flow and lymphatic drainage are compromised, leading to mucosal ischemia and necrosis. Moreover, obstructed bile is highly susceptible to bacterial infection and can result in a perforated gallbladder, a rare but life-threatening condition. A patient with cholecystitis is typically described as presenting with pain in the right upper quadrant or epigastrium. On physical exam, the gallbladder may be tender or distended. Initially, pain may be described as intermittent but will become constant and severe later in the course. Pain may be correlated with a diet high in greasy or fatty foods. Associated symptoms include diarrhea, nausea, and emesis, and remember that Murphy sign, if elicited, is specific but lacks sensitivity for a diagnosis of acute cholecystitis. In medical education, we often talk about the 4 F's of gallbladder disease: female, over 40 years of age, fat, and fertile. While women are indeed twice as likely to develop cholecystitis than men, the incidence in the latter has been found to be increasing, as well as in the elderly, ICU patients, diabetics, the obese, and those with rapid weight loss. Risk increases with age in both sexes, and Hispanics and Native Americans are particularly prone to developing gallbladder disease. If detected early, uncomplicated cholecystitis has an excellent prognosis. Approximately 20% of patients will require surgical intervention. Delayed diagnosis, however, increases morbidity and mortality, thus prompt evaluation in the emergency department is warranted. During bedside ultrasound examination of the gallbladder, the following findings may be seen: presence of gallstones, a sonographic Murphy sign, gallbladder wall thickening, ductal dilatation, pericholecystic fluid, biliary sludge, or an emphysematous gallbladder. However, the landmark study by Rawls and others found that the presence of gallstones in combination with a sonographic Murphy sign yielded a positive predictive value of 92.2% in the diagnosis of cholecystitis. Negative findings, no stones and no Murphy sign, were associated with a negative predictive value of 95.2%. This is important because it gives literature support to the goal-directed study idea, and it removes some of the diagnostic insensitivity of the anterior wall and common bile duct signs. Thus, your job when performing bedside ultrasounds of the gallbladder is to answer 2 questions. 1, are gallstones present? And 2, is a sonographic Murphy sign present? While it is helpful to ascertain whether a common bile duct is dilated, the anterior wall is thickened, or pericholecystic fluid is present, these are not necessary for diagnosis or disposition if the 2 principal questions have been answered. We will now review quickly the basic anatomy of the gallbladder. The gallbladder is a hollow organ situated inferior to the liver, and it is divided into 3 sections: the fundus, the body, and the neck. The neck tapers and connects to the biliary tree via the cystic duct, which then joins the common hepatic duct to become the common bile duct. It is important to remember that the gallbladder is not a fixed organ, so it may move to a variety of locations within the right upper quadrant. 2 anatomical rules may therefore be found helpful. The neck of the gallbladder possesses a fixed relationship to the main lobar fissure, or the MLF, and the right portal vein. The MLF connects the right portal vein to the gallbladder neck, and the fissure can be traced between the 2. This yields the so-called exclamation dot sign, which can be seen on the following ultrasound image. Here we find a medium echogenic material that is the liver, with the gallbladder anechoic in the middle, situated just inferior. We see the right portal vein off to the left, and the tissue that connects between the 2 is the MLF. The second anatomical rule is that the common bile duct is always anterior to the portal vein. If one experiences difficulty distinguishing the common bile duct from the hepatic artery, note that ducts tend to have brighter, more echogenic walls than either arteries or veins, as their walls are thicker and more fibrous. As can be seen on this ultrasound image, the triad of the common bile duct, hepatic artery, and the portal vein form the easily recognizable Mickey Mouse sign. On the current image, also note the relationship of the inferior vena cava and aorta to the hepatobiliary structures. If continued difficulty is encountered, color flow Doppler may be utilized to distinguish the structures, as flow will be visualized in the hepatic artery and portal vein, but not within the common bile duct. We will now discuss probe selection and positioning. The curvilinear abdominal probe, the C60, with a frequency ranging from 2 to 5 MHz, is ideal for examination of the gallbladder. The lower end of this range may be necessary for sufficient penetration in larger patients. However, sonographers should increase the frequency whenever possible, as the evaluation of gallstones, wall thickness, and pericholecystic fluid is significantly improved with better resolution. The microconvex or phased array probe, the P21, the same probe utilized in the E-FAST examination during traumas, may be used to image a gallbladder located posterior to the ribs. The gallbladder is identified with 3 basic approaches: the subcostal sweep, the X-7, and the flattened probe approach. The subcostal sweep is generally the most effective window and should be attempted first with the C60 probe. Start the scan with the probe in the longitudinal orientation, with the probe indicator oriented toward the patient's head. Instruct the patient to take a deep breath, and beginning under the costal margin to the right of the xiphoid process, sweep the probe inferiorly and laterally along the subcostal margin until the gallbladder is visualized. Next, we have the X-7 approach, which is an intercostal window. First, find the xiphoid process and move laterally to the right approximately 7 centimeters. Place the P21 probe perpendicular to the skin between the ribs. In most cases, the gallbladder will be found posterior to the liver parenchyma immediately beneath the probe. Finally, we have the flattened probe approach, which has its greatest utility in young patients who are in a supine position. Here, the gallbladder will be very anterior and cranial. In these cases, it is often helpful to point the indicator toward the patient's right and flatten the probe against the abdomen while aiming the beam toward the right shoulder. Fan the beam anterior to posterior to identify the gallbladder. Once the gallbladder has been identified using any of the 3 approaches, stop moving the probe, and now make small adjustments to create the best long-axis view. In the long-axis or longitudinal view, the gallbladder will usually appear as a pear-shaped hypoechoic structure with hyperechoic walls. As previously seen and now reviewed here, the relationship between the gallbladder and the portal vein, again connected by the MLF, will appear as an exclamation point. Fan the probe back and forth to scan the entire gallbladder in the long axis, identifying any pathology present. As with any organ of the body, however, the gallbladder should be viewed in 2 planes. After the long axis is thoroughly examined, pivot the probe 90 degrees and demonstrate the short axis, also known as the transverse view. The gallbladder will now appear spherical as seen on this ultrasound. Fan through the short axis from neck to fundus, again identifying and noting any pathology present. As mentioned at the outset of our discussion, 2 measurements are important when evaluating the gallbladder: the anterior gallbladder wall and the common bile duct. A thickened gallbladder wall is a sign of inflammation. However, this is a nonspecific finding and may be due to a postprandial gallbladder or another pathological process, some of which are listed in the following table. The key is to measure the anterior gallbladder wall at its most narrow point, maintaining a view in the short axis where the probe is perpendicular to the wall. If an oblique measurement is obtained, the wall thickness may be falsely elevated. For the gallbladder, a wall thickness greater than 3 millimeters is considered abnormal. Moreover, be certain to evaluate the anterior wall due to acoustic enhancement of the posterior wall, a topic covered previously in ultrasound fundamentals. Briefly, when sound waves travel through a fluid-filled structure, such as the gallbladder lumen, no signal attenuation occurs. Consequently, when those waves encounter the posterior wall, they will be so strong such as to obscure an accurate picture of posterior wall thickness. The second measurement in which we are interested is the diameter of the common bile duct, as dilatation is evidence of obstruction. As we have seen already, the common bile duct is most easily identified through its anatomical relationship with the hepatic artery and the portal vein in the short axis. Together, they form the portal triad and are easily recognized as the Mickey Mouse sign. The common bile duct and hepatic artery form Mickey's ears, with the indicator directed toward the patient's right. The right ear will be the common bile duct, and the left ear the hepatic artery. With this said, the best way to evaluate the common bile duct is in the long axis, as gallstones or external compression may occur at any point in the tubular structure. Maintain the Mickey Mouse sign in the center of the screen and rotate the probe 90 degrees without changing the location of the probe on the patient's skin. In the long axis, 3 echogenic lines will stretch across the screen. The line closest to the probe will be the anterior wall of the common bile duct. The second line is the shared anterior wall of the common bile duct and the portal vein. Finally, the third line is the posterior wall of the portal vein. If there is confusion differentiating between the common bile duct and the portal vein, color flow Doppler can be utilized. The portal vein will demonstrate flow and the common bile duct will not. The common bile duct should be measured at its largest diameter in the long axis. Calipers should be used to measure from the interior margin of the anterior wall to the interior margin of the posterior wall. It is helpful to remember that the diameter of the common bile duct increases with age and is commonly said to be anywhere in the range of less than 1/10 of the patient's age. In healthy patients, the common bile duct is typically less than 6 millimeters, while anything greater than 8 millimeters is considered abnormal. We now turn to some of the most common abnormal images that you will find on ultrasound examination of the gallbladder. In this first ultrasound, we see a picture of multiple gallstones. We see here 2 large gallstones that are marked by the orange arrows, one impacted at the neck and the other within the lumen of the gallbladder. The gallstones reflect virtually all of the sound waves. Therefore, the edge of the stones are very bright on the screen, and the tissues behind the stone are obscured by shadows because no sound waves make it past the stone. This is called posterior acoustic shadowing, or the headlight sign. In this next ultrasound image, we see yet another stone lodged in the neck of the gallbladder. This is often referred to as the SIN sign, where SIN stands for stone in the neck. This would be more indicative of acute cholecystitis given a correct clinical scenario. In this third ultrasound image, we see the medium echogenicity of the liver parenchyma towards image left, with the anechoic tubular lumen of the gallbladder directly toward its right and situated in the center of the image. Here, we are looking at gallbladder wall edema secondary to a gallstone in the neck. As signified by the orange calipers on the screen, the anterior gallbladder wall is thickened, here approximately measured at 7.1 millimeters. Recall that the normal gallbladder in a healthy individual measures less than 4 millimeters. When we measure the gallbladder wall, we measure at the most narrow point of the anterior wall in the short axis. We take care so as not to measure the wall at an oblique angle, thus giving us a falsely elevated value. Notice also in the image the presence of the SIN sign with posterior acoustic shadowing. This is likely the cause of the luminal distension and the wall thickening. This fourth ultrasound study is indicative of biliary sludge. Gallbladder sludge is likely made up of very small stones, making the bile viscous and giving the bile echogenicity. The sludge is identified on ultrasound as a dependent layer of variable, non-shadowing echogenic material forming a meniscus within the gallbladder lumen. Frequently detected in states associated with biliary stasis, such as limited PO intake, sludge may be a precursor to gallstones and has also been related to pathology such as acute cholecystitis and acute pancreatitis. In this fifth and final ultrasound image, we see pericholecystic fluid. Pericholecystic fluid is generally found in wedges around the acutely inflamed gallbladder wall. It is most often seen posterior to the gallbladder, at or around the neck, but may also be seen layering on the anterior wall, as in the current image. Having covered some of the abnormal findings that you might encounter with patients experiencing right upper quadrant abdominal pain, we now provide some scanning tips. If visualization of the gallbladder is proving difficult, 2 guidelines will generally prove helpful. 1, have the patient take and hold a deep breath. This may bring the gallbladder below the level of the costal margin, aiding in visualization. 2. Change the position of the patient. Keep these tips in mind as we survey the common challenges encountered in the gallbladder exam. First, if you're unable to visualize the gallbladder, if the patient is supine, use the left lateral decubitus position to bring the gallbladder more anteriorly in the peritoneal cavity. If the patient is sitting up, have them lean forward. If the patient has eaten, wait at least 1 hour before imaging. The gallbladder is easier to visualize when NPO, as this causes the gallbladder to dilate. What happens if you have a questionable sonographic Murphy sign? First, ensure that you are not pressing directly on the ribs and eliciting pain in this manner. Ask the patient to take and hold a deep breath, again so as to lower the fundus below the costal margin and aid in visualization. Now, if you're unable to visualize the common bile duct, again have the patient take and hold a deep breath or change position. You may also use color flow Doppler to distinguish the hepatic artery and portal vein from the common bile duct. Remember, the common bile duct will demonstrate the absence of flow. If you have rib shadows, use the P21 probe. Angle the probe obliquely to visualize between the ribs and ask the patient to take and hold a deep breath, again so as to lower the fundus below the costal margin. If the presence of non-shadowing objects are in your image, increase the probe frequency. High-frequency sound waves make shadowing more pronounced. You may also change patient positioning. Remember, however, that gallstones, unless they are impacted at the neck of the gallbladder, are gravity dependent. Therefore, if an object does not respond to gravity, it may be a polyp or a tumor. In these cases, further imaging by radiology is warranted. Now that we have covered the basics of bedside sonography of the gallbladder, let's review the main take-home points. We have 3. First, if gallstones and sonographic Murphy sign are demonstrated on exam, you have the diagnosis of cholecystitis, proceed the treatment and disposition. 2. If you are experiencing difficulty in visualizing the gallbladder, have the patient take and hold a deep breath so as to bring the fundus of the gallbladder beneath the costal margin. 3. If you are still experiencing difficulty, try changing the positioning of the patient. If they are sitting, have them lean forward. If they are prone, move them into the left lateral decubitus position. You are now ready to perform a bedside ultrasound of the gallbladder. Thank you for your attention and be sure to check back for future episodes.